also want to try. Does anybody agree with her? Is there anybody that thinks otherwise? Nobody? How many are we on the call? I can't even see because I'm showing my entire screen.
Currently, we are 32 in the call. We are 32. And okay, Rejoice Ebube, please say something. You can unmute and say something. Rejoice Ebube.
Okay, good evening. I think
I'm trying to.
Don't worry, Rad Cranium, I'm going to do that for you. I'm going to select what are going to speak. Just concentrate on them, being our instructor. Leave the rest for me.
Okay.
All right.
Because I'm looking at the entire screen. Okay, thank you.
All right. Please go on, Rejoice.
Okay, I think it's pneumothorax because of the partial collapse of the left side of the lungs.
Okay, when you say pneumothorax in layman terms, what do you mean?
That is presence of air in the pleural space, which makes it completely or partially collapse.
Okay, we have pleural effusion, we have pneumothorax. Is there any other counter opinion?
Mania Kanabasi, please unmute yourself and speak.
Okay, good evening all. I agree with what the first person said. I think it is pleural effusion on the left side. Yes.
All right. Radwari, do we have any other person that also wants to speak? Or that's all?
No, that's all. That's all.
All right. So if you look at, let's just quickly look at this because of course you guys did this yesterday. If you look at the image, you were taught, how to, pattern recognize a chest radiograph, how to evaluate a chest radiograph. And they also taught you guys, how to assess the quality of a radiograph. And to evaluate a radiograph, you are using the A, B, C, D, E. Some can even add F. F there is for foreign body, but you know what the A and the B is all about. So if we are looking at the airways now, if we're starting from A, you are looking at the trachea, and of course, you get to the carina of the trachea. I don't know if I can use a pointer here. Okay, can you guys see the pointer?
Yes.
Yes, we can.
All right, so you can see this is the trachea, and this is the carina of the trachea, and this is the right bronchus, and of course, this is the left bronchus. And even though we know that some part of the heart tends to deviate the trachea a little bit, towards the right, but you can see that it's a little bit more deviated than usual. And we have that, for our airways already. And if you look at the breathing, the breathing is adequate. We are looking at the lungs parenchyma itself, and we can see, the normal vessels within the lungs. We can see the hilum. We can see the lungs is well inflated on the right. Now, if we go to the left, we also see the markings, but we can't see the entire lungs. And then we just keep that, one side. If we go to the cardiac and circulation, we look at the heart, and objectively, if you are looking at this, or subjectively, without any measurements, you can see that this heart is not really, enlarged. If we go to the diaphragms, we can see that, of course, the right hemidiaphragm, it appears normal and is dome shaped as it should. But when we go to the left, the diaphragm is somewhat obliterated. You cannot really, visualize it, right? So if we have assessed all of this in entirety, and we have looked at even the lungs parenchyma, we have not seen, sufficient, issue within the lungs. We have looked at, of course, the airway, and we said that there was a little, though not sufficient, a little deviation, towards the right, which we also said that, or I also said that there is usually a normal deviation. But you see, this is a little bit, accentuated, towards the right a little bit. So this is, most likely pointing towards, pleural effusion. However, effusion is a more broader term, right? So hemothorax is still classified under effusion. Hydrothorax is still considered under effusion. Empyema is still considered under effusion because empyema is the accumulation of pus within the pleural cavity. Hemothorax is the accumulation of blood within the pleural cavity, and hydrothorax is the accumulation of just, clear serous fluid within the pleural cavity. So this is a case of effusion, right? And why do we say it's a case of effusion? Somebody said, and this is likely a case of pneumothorax. We all know that, air is radiolucent. Air is not radio opaque. So anywhere you find air within, a chest exams, it's supposed to be radiolucent. That is supposed to be dark. So for us to say that there is pneumothorax, that means we should be seeing, dark areas around the thorax before we even talk about other features of, pneumothorax, like you are not going to see lungs markings within the area of that air, then you are going to see a pleural line. But we are going to get to that in detail. So this is obviously not a case of, pneumothorax because, of course, this area is not dark, there is no air there. So it points more towards pleural effusion. However, what we are doing here is important to understand that what we are doing here is not enough for you to go to work on Monday and tell your radiologist not to resume anymore, that you have taken charge. So what we are doing here is to enable us to identify some patterns and then call, for emergency when there is one. Because it will be so bad that, you do an exams and it's a life-threatening exams, and then you just, move around because the radiologist is not on duty, and then something bad happens to the patient, just because you don't even understand the images you're taking. This is quite important because, in fact, there was a time I was doing an echo with a cardiologist, and we were scanning the patients, and the cardiologist was like, "Why did you ask the woman why she came for the echo exams?" And she said that her X-ray report was cardiomegaly. And the cardiologist, after checking, the heart was normal actually. So when the guy checked and checked, the man checked and checked, and there was nothing there, he was even forced to tell the patient, "Oh, bring the chest X-ray, the film that you did." So the woman brought the chest X-ray. If you see the way the cardiologist, in front of me, analyzed this chest X-ray, the man was like saying that the inspiratory effort is poor. So because the inspiratory effort is poor, it may, falsify the cardiomegaly. It may make the heart look bigger, because he was telling me that the heart is sitting on the diaphragm. That to them, if the heart is standing and is still greater than 50%, that's when they can even consider, cardiomegaly. And he also told me that even this cardiomegaly sometimes may not really mean anything. When somebody tells you cardiomegaly means the heart is big. It does not tell you if it is ventricular hypertrophy, though sometimes you might have a clue. But it could be ventricular hypertrophy that is making it big. It could be atrial enlargement that is making it big. It could be volume overload that is making it big. Sometimes it could even be pericardial effusion. So there are some pericardial effusion that, they will just list as cardiomegaly. Meanwhile, it's just pericardial effusion. Though there are some features on chest X-ray that can suggest, pericardial effusion when the heart looks like a bag. A bag. This bag that they normally put coin that year, money bag sign. So, but that's not even still sufficient to say there is pleural effusion. So the man was like telling me most of the time when, they diagnose patient with this cardiomegaly, they come for echo, and, the echo just shows normal findings. That he knows that is likely, due to the, inspiratory effort and all. So I wanted to use this overview so that we can know, what we are going to be looking at in entirety during the pathological patterns. I don't know if everybody can hear me.
Yes, we can hear you.
Okay, so in pattern recognition in chest radiograph, it refers to identifying characteristic, radiographic appearances associated with disease processes. So this association with disease processes can help us to be more, definite in our diagnosis. That is, all what I want you guys to understand, because most of the features on chest X-ray may likely overlap. A lot of features overlap. So they tend to associate it with some changes in the thorax or in the lungs or with the heart to say, okay, because there is this change, then it's likely this. So the importance of pattern recognition will include, it helps to narrow differential diagnosis. Yes, I just said that. It improves the speed and accuracy of image interpretation. Yes, I just said that. Assist in systematic, chest radiograph treating, because there are even some things that the doctor might not query. I think there was a time that we were doing a discussion on our roundtable group, study right group, and we were talking about, I think, coarctation of the aorta. And we said one of the features of coarctation of the aorta is a 3 sign on the aorta. And then we also said is a notching of the ribs. We see the intercostal arteries notching the ribs. And then somebody now asks, that this chest X-ray that I'm sharing is looking like the same, there's no much difference. So if there is a systematic approach, in a case of maybe another finding, an incidental finding that probably the doctor is not even worried about, then the radiologist is going to pick it, right? So it's not only for you to, maybe the doctor is now querying pleural effusion, and then you now look, there's no pleural effusion, you now send the patient back. No, you have to look at the chest systematically, because there are some things that you can pick that the doctor didn't actually, consider for that might even also contribute to the patient's symptoms. It can also enhance clinical decision. There are sometimes that a doctor will send a patient to you and they are not even querying anything. And let's say you are let me say you are in the shoes of the radiologist and you make a report and send the patient back to them. And then they will now tell you, oh, did you check if the ribs is broken? Oh, did you check if there's a fusion? And then you now be like, no, you people did not query a fusion now, so I did not check. That would be very wrong. So that means you will now have to go back. That will delay clinical decision. If it's in a case of emergency, they might not know what to do. They have to wait for you to go back and look at the radiogram. That's why the systematic approach is very important, so that the part that they have queried and the part that they have not queried, you are going to assess them. So there are major pathological patterns in the lungs. Either these diseases or these pathologic changes are going to affect the alveolar. Alveolar is like the unit of the lungs. They help in gaseous exchange. So either they are going to affect the alveolar, or they are going to affect the interstitium, or they are going to affect the pleural space. So all of the lungs pathology, or most of the chest pathology, excluding the hearts, are mostly going to affect the unit of the lungs, which is the alveolar, or is going to affect the supporting structures of the lungs, which are those interstitial spaces that help to, hold the alveolars together and give the lungs a shape. Or it can even affect the covering and the space in between the lungs, So most of our patterns is going to be revolved around, this alveolar, interstitial, and then the pleural. And you can see on this particular image here, you can see consolidations. You can see, consolidations are mostly associated with alveolar patterns. You can see, these reticular patterns mostly associated with interstitial, pathologies. You can see nodules. You can see smaller nodule. You can see a mass. You can even see atelectasis, which is, volume loss of the lungs. Please, am I too fast?
Very true, very true.
We have two.
Okay. So for the alveolar pattern, this occurs in the alveolar when the alveolar becomes filled with, substance like fluid, pus, blood, and any other cells other than air. So you are mostly supposed to have, air inside the alveolar. And when there is fluid, pus, blood, or any other thing that is not air within the alveolar, it tends to cause obstruction. And this obstruction will interfere with gaseous exchange, because it's not going to allow, the normal oxygen and carbon dioxide, which is very vital for the cells of the body. So it might not affect the entire lungs. It might affect maybe some segments. It can affect some lobe, but mostly either it's segmental or it's lobar. It can even affect, the entire, ipsilateral lungs or even both lungs. So what could be the common cause of this? Inflammation of the lungs, which is pneumonia, can cause this. Pulmonary edema can cause this. Pulmonary, hemorrhage can cause this. Aspirations, when you want to swallow your saliva and it somewhat gets to your, your lungs, or you want to drink something and you are choked, it gets to your lungs, or you are swallowing maybe granules and it gets to your lungs. Those are aspirates. Acute respiratory distress syndrome, can also be a reason why, you could have fluid, you could have pus, you could have blood, or even, any other thing other than air being inside the alveoli that can cause difficulty in gaseous exchange. And the radiographic feature will include, you can see, homogeneous opacity in the area in the affected area, like you can see on this particular image. You see it hazy patterns, in this particular area of the lungs. These around the middle lobe of the lungs, and mostly these patterns don't appear like nodules. We said, because some people might be like, is that not a mass? Nodules will be either it is round, or it is well circumscribed, or it is bigger. But when you are talking about alveolar infiltration, you will see that it's not looking as if it's circular. It doesn't have a definite shape, but you will definitely know that it's localized to a particular segment, or it's localized to a particular lobe. So you will see area of dense white appearance, and it's often localized to a segment or a lobe. And the strong supportive sign that you will know that, this is definitely an alveolar disease is a bronchogram. A bronchogram simply means the prominence of air within the bronchus that is not supposed to be that obvious. So you are seeing the bronchus very obvious, right? And you are seeing air within it. Normally, you are not supposed to see. That means there is an obstruction, and the air tends to accumulate within the proximal bronchus, just proximal to the area of the obstruction. So obstruction in lungs disease doesn't necessarily mean there's a mass. If there is a fluid anywhere, it's obstruction. There's a pus anywhere, it's obstruction, because it's considered something that impedes gaseous exchange. So it's considered generally as obstruction. So if you look at the trachea here and you are looking at the bronchus here, you can see that though the image is not so clear, but you can see that it's very, very obvious, just proximal to where you are having this area of consolidation within this particular segment. And this will definitely tell you that, this is an alveolar pattern. Like I said before, there will be ill-defined margins. So they are not looking so rounded like a nodule, like the way you have a particular nodule. That's the difference. And when you see this air bronchogram, is mostly telling you that definitely this is an alveolar disease. So for interstitial patterns, they occur when disease affects supporting tissues of the lungs rather than the alveolar itself. So the interstitium are not areas where you have gaseous exchange. They are just areas that support the alveolar. So there are some diseases that might affect these tissues that tend to support the alveolar, and they are mostly fibrotic diseases. Mostly diseases that can cause fibrosis, are mostly diseases that affect this area. And with the interstitial pattern, because the air in the alveolar is hardly affected, the lungs, of course, will still be aerated because there is no obstruction to the area of where the bronchus are going to. So you know that the bronchus, are mostly what is connected to the alveoli. So it's only when you have, an obstruction in the alveoli that you can have that bronchogram. You cannot have it in interstitial pattern because, of course, they are not affecting where the particular gaseous exchanges are being taking place. So the common causes will be, like I said, fibrotic diseases, pulmonary fibrosis. Of course, tuberculosis can cause fibrosis as well, interstitial lung disease and sarcoidosis, And most of these, like this sarcoidosis can just, are multi-systematic. It can affect multiple systems. You can even have testicular sarcoidosis. You can have splenic sarcoidosis. It affects multiple systems in the body, not just the chest, just like the miliary tuberculosis. So that's why we have pulmonary tuberculosis and we have miliary tuberculosis. Miliary tuberculosis flows through the blood. So you have tuberculosis of the liver, tuberculosis of the spleen, tuberculosis of the testicle. That is a miliary tuberculosis. But in pulmonary tuberculosis, that means it's loculated to the lungs itself, which is the one that we are going to be talking about today. So for the interstitial patterns, it's going to be nodular. Either you can have a nodular appearance, like you can see these tiny, radio opaque areas, very tiny, just that this image is, just put here to help you understand what is on this particular chest radiograph. But you can see dot, white areas around almost the entire parenchyma of the lungs. However, even with this, the lungs is still rarely see any bronchoalveoli, even though the image is just crossed. So these are reticular patterns. Reticular patterns are more like they resemble nets. Net-like patterns. That's another name for it. Net-like patterns. So you can even have both of them. You can have nodular patterns. You can have reticular patterns within the same lungs. That will tell you that it is an interstitial disease and not an alveolar disease. So what are the general radiographic features of interstitial disease or patterns of lung disease? You will have diffuse hazy opacities. You can have fine linear markings. Take note of diffuse. Mostly is always diffuse. We said that alveolar patterns are usually segmental or lobar. Rarely would they be diffuse. Very rare. If they are diffuse, that means of course that person is not taking in oxygen at all. So diffuse and hazy opacities, you can have fine linear markings, you can have reduced lung clarity. Of course, see, we are not really seeing the lungs very well because of these opacities in the entire parenchyma of the lungs. And mostly it can involve, the both lungs, so it can be bilateral. And of course, sarcoidosis, that's one of the features of sarcoidosis. Sarcoidosis is mostly bilateral. So if you see a lesion, apart from metastasis is one of the common lesions that is bilateral as well. So, but of course, metastasis looks more like a cannonball. So if you see a more diffuse lesion, it's always mostly pointing towards sarcoidosis, especially when there is lymphadenopathy. So are you guys seeing what I'm doing?
Yes,
Yes, sir.
we can see.
Yes, sir.
Yes, sir.
Okay. All right. Let me go to the next slide. So you can have pleural patterns, right? Pleural patterns where there's abnormalities affecting the pleural space. And these pleural abnormalities can be subtle. It also can be very obvious, very bad, that it can cause a mediastinal shift. If you all remember your anatomy, the mediastinum is just the space in between the lungs. And we have different part of the mediastinum. They have the superior mediastinum, where you have the aorta, the arch of aorta. They have the anterior mediastinum just in front of the heart. They have the middle mediastinum where you have the heart itself. They also have the posterior mediastinum. So because of this is a space, this is just a space, and the heart is what is filling most of this space. And just like any other part of the body, when there is an increased volume in a particular body part, it tends to take up most of the space of that area. Let me give you an instance. Let's say somebody that is starving, has not eaten for a while, and then you see this person sitting down to gulp like maybe 6 cups of gari. They finish it, they eat it to the end. And you wonder, where is this food going to? Because even initially, before the person even ate, the stomach may likely have remained the same. And then this person finished over 6 cups of gari, and the stomach, at the abdomen, is still looking the same size. It's because at that point where the stomach is enlarging, it's taking up space, it's pushing other structures away and taking up space. There's no like free space in the abdomen. I've had a conversation with somebody once, and they mentioned that they remove an organ because of that there was a free space there. No, there is no free space in the abdomen. What you rather have in the human body is potential space, not its actual space. Just like we have the pleural space, is a potential space. It's not as if it's an obvious space for you to see. You can't see it. You can only see it when there's an abnormality. Just like what is written here, the space is only clearly visible when it is abnormal. So even if you go to the abdomen, spaces like the posterior cul-de-sac or patch of Douglas, you shouldn't see them until there's something there. So there's no free space in the abdomen. But when something becomes have more weight and tends to occupy more space, it tends to push the other structures to the other side, and then you can have what is called the mediastinal shift in the chest radiograph. So to assess the pleura, you are going to check carefully around the edge of the lungs where abnormalities are rarely seen. So you start and end at the hilar, check for lungs vascular markings all the way to the edge of the chest, and then check also inward. What is this saying? We already agreed that normally you cannot see the pleural space. until it is abnormal. So if you are looking at the lungs, you are supposed to see a full, if you are looking at the chest radiograph, you are supposed to see a full aerated lungs with vascular markings, extending almost towards the edge of that particular lungs, towards the ribs, like towards the lateral side this way, But when you are now looking at the lungs and you can see some vascular markings towards the outer border, the lateral edge of the lungs, that means there's something wrong with that area. You either have to zoom in or recheck the image carefully. And pathology where you can see that is the pneumothorax. So because in pneumothorax, probably due to trauma or whatever condition that may happen, the lungs volume has now reduced and the air within the lungs is now leaking into the thoracic cavity. So because it is still air, the thoracic cavity will still be dark. But the defining sign would be that there are no lungs markings, there are no vascular markings within that area. And of course, you are going to see a pleural line. That pleural line means the edge in which the remaining lungs is being shown. Because this lungs is not really inflated the way it should be. So you are going to see a clear border between the lungs tissue itself, the air inside the remaining lungs, and the air outside the lungs, like within the thoracic cavity. You can also see where fluid would accumulate within the pleural, the costophrenic angles, and obliterate these angles. So these angles are not going to be very sharp the way you are seeing these ones being very sharp. You are going to see them being obliterated, and they are going to form what is the meniscus sign. It's going to form a little bit like a half moon shape here. They call that a meniscus sign. That would be pleural effusion. And I said before, in the beginning of this class, that we can also have, pus collecting there. You can have blood. You can even have a mass, collecting there. Where chest X-ray is not really sufficient for diagnosis, you can, other modalities can be advised, like, you can do ultrasound for the lungs as well. So ultrasound for the lungs can be advised. Chest CT can also be advised. MRI also and biopsy are other tests that can also evaluate lung pathology. So common chest pathologies, and we have explained most of the patterns, and we are going to look at the common pathologies and how they may likely be looking at, and also considering the patterns associated with them. And the major ones that we are going to be looking at today is pneumonia, tuberculosis, cardiomegaly, atelectasis, pleural effusion, pneumothorax, lung nodules, and masses. So you have to note that for proper recognition of these pathologies, it's essential for accurate image critique and your clinical decision making. So for you to help in clinical decision making, you have to look at the chest critically using the patterns that we were given yesterday, and I've also mentioned some of them today. So pneumonia. Pneumonia is simply an inflammation or infection of the lungs parenchyma that produces an alveolar pattern on a chest X-ray. And remember, we said alveolar pattern, you are going to have a bronchogram. Very, very important that you are going to see a bronchogram, and you are going to see consolidations within a particular segment or a loop. And common causes of this infection could be bacterial, it could be viral, it could be fungal, it could also be aspiration. And pneumonia is mostly associated with the lower lobe of the lungs. Why? Because the lower lobe of the lungs are gravity dependent. And when you have, and this is mostly, we have different types of pneumonia. We have the bronchopneumonia, and we have the aspirate pneumonia. So aspirate pneumonia is when you have, a particle that is not supposed to be within the lungs. Of course, when it gets to the lungs, even your saliva itself, when it gets to the lungs, it can irritate the lungs and cause inflammation, which can lead to pneumonia. So because saliva is gravity dependent, it definitely goes to the lower lobe of the lungs, and most likely the right lower lobe, because of course the right lower bronchus is more bigger than the left and shorter, and can easily, somewhat more vertical, and can easily allow particles or fluid or foreign bodies to pass through them and get to the lower lobe, because the lower lobe is gravity dependent. Patient commonly presents with fever, productive cough. Of course, if there is any, this is the secret, even when you are doing a scan, if there is any inflammation of any kind, inflammation like pneumonia, appendicitis, hepatitis, pancreatitis, whatever inflammation you may be talking about in the human body, lymphadenitis, is the number one thing that comes with it. But because we are also talking about the lungs, whatever happened to the lungs, when there is an inflammation, there is fluid secretion. And because there is fluid secretion, there will be cough. Because it's more like you are choking, just like when you are choking, you cough. That fluid it tends to cause obstruction. And because of this obstruction, as a reflex, trying to remove that fluid. But because this inflammation persistent, because can continue for a long time, that's why people can that cause is being, and the cause is being treated. So productive in the sense that inflammation will of course cause fluid secretion. So you'll be coughing out. It can be any whatever form depending on what is causing it. Of course, you have chest pain because it's inflammation. You have dyspnea, of course, yes, because there is obstruction. The person will have dyspnea and will generally feel unwell, which is malaise. So what will be the radiographic feature of pneumonia? You have consolidation, yes, you have air bronchogram, you have loss of normal lung transparency, or you can say lucency in the affected region. So the affected region will become whiter than it should, not dark like the rest of the lungs. Yes, so you can look at this, you can see this this segmental consolidation. You see the way it's looking, it's not looking like a mass, you see, affecting this particular segment. So this, of course, is still a pneumonia, and we don't have it at the lower portion because I said some pneumonia are gravity dependent, most of them actually, but some of them still tend to affect the middle lobe, the upper lobe, like the bronchopneumonia and the rest. And you can also see here, this one is affecting the lower lobe axis, and you can see, if you are looking at the image very well, you will see that the bronchus here is very, very obvious. Not so obvious. Sorry, the image is not so bright, but you can see the bronchogram there. Tuberculosis. So this is a chronic granulomatous infection caused by Mycobacterium tuberculosis and may produce cavitary or interstitial pattern. So most cavities, you see
It seems our instructor's network has interrupted. Let's just hold on a bit till he reconnects. Can you all hear me?
Yes, sir.
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
All right,
Yes,
let's
sir, we
just
can
stall a
hear
bit.
you.
Let's just stall a bit. His network has interrupted. I think he is connected. Are we following?
Yes, sir.
Yes, sir. Yes,
All
sir.
right, please just keep your questions, all of your questions. When he's done, you're going to ask him as many questions as possible. Please, let's just wait. The network is it still here? I don't think it's still here. All right, let me just text him. Alpha. Okay, okay, okay.
I'm very sorry. I'm very sorry I was disconnected. Okay. Okay, can you guys see my screen?
Yes, sir.
Yes, sir. Yes, sir.
Okay. I'm sorry. All right, you are still seeing?
Yes.
Yes, we are still seeing the screen.
Okay. Uh, I'm trying to. Okay. Right. So please, where did I stop? If you're with me.
Yeah, introducing tuberculosis, like and definition tuberculosis.
Okay. Okay. Yes, I'm very sorry for that. I know my network disconnected. All right. So tuberculosis is a chronic granulomatous infection caused by Mycobacterium tuberculosis, and it may produce cavitary or interstitial patterns. So you can see cavities, and these cavities are mostly caused by destruction of that particular area of the lungs, and mostly is contributed by the body as well. Mostly is, can you people see my entire screen?
So I don't think we are seeing the part you are reading, or the part you are on right now.
Okay, let me reshare again. Let me redo. Let me. Okay, how about now?
We are not seeing. You are sharing. I think you are sharing. You have not shared the slide.
The slide.
Yeah.
Otherwise. Let me just see if I can share the entire screen. Okay, how about now?
All right, yeah, we can see. Yes, we can see.
Okay, you can see now.
We were able to. Okay, yes, we can see. We can see yes, we can see it now.
Okay, thank you. Let me just go to where we were. Okay, so tuberculosis is a chronic granulomatous infection caused by Mycobacterium tuberculosis. And this bacteria may produce, cavitary and interstitial pattern. Mostly, this cavity is also caused by, our body defense mechanism. So when this, the bacteria, starts infiltrating a particular area, they become relaxed and they try to own that area. So your body tries to fight this and then send some macrophages to go there. So as a result of these macrophages trying to eliminate this, this bacteria, they destroy some part of the lungs tissues. And this part that are being destroyed, entraps air within them, and they cause the cavity that we see on chest X-ray. That's just what the cavity is all about. So you will see, air that are being trapped inside an area of a destroyed, lungs tissue. And I said this is different from abscess, because in abscess formation, you are going to see, air fluid level within such lesions that may have similar appearance. Tuberculosis may also produce interstitial patterns, and we said interstitial patterns are patterns that have reticular nodular patterns, and they do not mostly, they are not associated with a bronchogram, different from, alveolar patterns. Patient may present with chronic cough, weight loss, night sweats, hemoptysis, and fever. So radiographic features of TB mostly, are seen in the upper zone. So you will see opacities within the upper lung zone. It's most likely TB because mostly, TB this bacteria tends to move to area that is, of high oxygen, concentration. And you have high oxygen concentration in the upper part of the lungs. Let me see if I can use my pointer. So you can see, like in this particular disease condition, you can see the tuberculosis affecting this area. It's only when they have completely destroyed a particular area that they now try, to move to other areas. When they have defeated this side, destroyed this side, you see them try moving. And that's why you see it's very important that, TB patients, take their drugs timely before the lungs tissue is completely destroyed. Because sometimes in the management of tuberculosis, it can even lead to lobectomy. That's removal of a particular lobe of the lungs. Because then once that lungs is destroyed, they might not even want, any form, any residue of that bacteria to move to any other adjacent lungs. So they can just do a surgery, cut off that particular lobe, and, so that the other lobes can be free. That's after they have successfully treated the infection. Because how that lobe is diseased, they can cut it off. In some instances, they can even, demand them or require them to remove an entire lungs, and then the person will be living with one lung. I've seen a lot of, patients coming to do chest X-rays, and they have just one lung. The other ones have been removed, probably due to, probably cancerous, they're associating a cancerous disease, or can even be chronic tuberculosis. So you will see cavitation, loosened cavities within areas of consolidation. So you see within indicative of tissue destruction, like I said before. So within this area, you can even see something that nearly looks like it is this, this particular area, but it's not so definite. But of course, we can consider this as a cavitation. So you can see within this area of opacities, consolidations, there is still an area that is still looking loosened a bit. One might think that, oh, the other particular part is still surviving. No, it might just be as a result of cavitation. And you see some air are being trapped there. That air cannot be used for any form of exchange at all. So you can even see fibrosis, you can see hilar lymphadenopathy, where you see enlarged lymph nodes in this area. These are the hilar of the lungs here for the right, and here around here for the left. So you can see the lymph node around this area, like, of course, being very prominent, and you can also see the upper parts, the upper, zone of this particular lungs is also being affected. So now that we know, the principle, let us see it in action. Everything that we have learned, everything that we have talked about, let's see if we'll be able to, identify. So, I will, some persons will also try. I myself will also try. We'll try and see. So, activity 1, pattern classification. Classify the following radiograph into pathological patterns, and this is the first radiograph. So looking at everything that we have talked about, we have talked about alveolar pattern, we have talked about interstitial pattern, we have even talked about pleural pattern, as most of the patterns, that lung diseases present themselves. So looking at this particular radiograph, what pattern could this be? Is it an alveolar pattern? Is it interstitial pattern? Is it even, pleural pattern? Is there anybody that wants to try? I'm not seeing, I don't know if I should minimize and go back.
Don't worry, I'll do that for you. Anye Kanabasi can unmute and speak. Anye Kanabasi can unmute.
Okay, good evening all.
Good evening.
I think this is an alveolar pattern
Okay, why?
because according to the characteristics, the features he gave, he said there's a homogeneous opacity.
Yeah.
Secondly, along the hilar, that's this middle side, there are ill-defined margins.
Okay.
So I think that's why I would say it's an alveolar pattern.
Okay. So is there any other person that also wants to try? Well, is there any other person? Maybe some other person will just try the next one. So yes, I agree with her. This is an alveolar pattern because you can see this consolidation, localized to a particular segment in this area. This is not reticular pattern. This is not nodular. We said reticular, you will see some, fishnet areas, and reticular and nodular, which is interstitial, is more diffuse than this. But you see, this is, localized to this particular segment. And if you zoom the image well, you will see, bronchograms as well. So yes, this is an alveolar pattern. Okay, can another person try this? Sorry for the image quality, but at least for the purpose of learning. But when you are doing your own, you do it well. Like in this image now, you see the schizophrenic angle has cut off. So please, don't go and maybe do something. Your chief will say, do it again. You now say, no, carry this image and show to them. I say, no, the one they taught us in study that. So we are just doing this. Yes, we are just doing this for the purpose of demonstration, not, when we are talking about adequate, I think yesterday they taught you guys right, how to assess image quality using the right, looking at the rotation and all that. So, but now we are looking at the lungs itself, and of course, the image has captured the lungs where we are looking at. So, is there anybody that wants to try this particular pattern?
Nobody. I'm just okay. There's one person. Rejoice. Okay, Rejoice. Please unmute and speak.
Okay, good evening. I think this is interstitial pattern because it is diffuse and it has the net-like shape present in the both lungs.
Yeah. You're actually correct. Though, this image did not really help us so much because you can see the, the exposure factor. Maybe the patient is a little bit fat, so they would have increased the KVP. But you can see that the exposure factor is, is also interfering with adequate.
Anye Kanabasi, your hand still up. Is your hand still up? Anye Kanabasi, you want to add something to what Rejoice said? Okay. Please go on, Right, and cranium.
Okay. So yes, this is interstitial pattern. That means we are all following. That means I'm a good tutor. Ah, I can appreciate myself small.
Yes, you are. Yes, you are.
So if you look at this one, is there any other person that also want to try? We say we have 3 patterns. We have, alveolar, interstitial. We also have pleural. So who also want to try this?
What's going on, guys? Yesterday we said we are going to ginger. Oh. We are not the shy type. We are phenomenal radiographers. Please, 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 please. Let's all raise up our hands. We know the answers. All right, Benny.
Yeah, they do.
Good evening, sir. Good evening, everyone. I think this one
Good
is
evening, Cherry.
plural effusion pattern, plural pattern.
All right, thank you very much, sir. So this is a plural, pattern, and you can see that we are not even seeing, the cosophrenic angle on this side, and you can see that the fusion accumulates all the way, to the middle, to the area of the middle lobe of the liver, and because of this, in patients like this, the radiologists will not even be able to measure the cardiothoracic ratio, so they will just tell you that they can't accurately estimate the cardiothoracic ratio. But from your estimation, from looking at this image, you see that the heart is not enlarged, obviously. But they cannot, you have to give values to why you say it's not enlarged. So most of the times, they don't even comment on it, because this has completely covered the right border of the heart. All right. So we are going to use, some clinical history, because it's actually very important. Some of the times, like I said, we are looking at images with, radiolucents, radio opacities, and radiologists are using this to give a diagnosis. So sometimes they need history, they need, has there been any previous intervention? Is this patient on a medication? Is this patient hypertensive? Is this patient coughing? Is the patient coughing out blood? Is the patient symptomatic? They just need you to tell them something, They just need you to tell them something, because with the little thing you are going to tell them, they are going to be able to use this, to make accurate diagnosis. So the clinical correlation here is, of course, this is a student task, not my task. So interpret the radiograph and provide likely diagnosis. So for the clinical presentation, patient presents with fever, very important, of course. I mentioned what fever is mostly associated with. Fever, productive cough. I also mentioned what productive cough is also associated with. Chest pain. So with this clinical history, presentation, what do you think, would be the most likely, pathological pattern here? These lungs. Can anybody try? I wanted to try, but they said it's student tax.
No, it's student part, sir.
Okay.
All right. So they will try first before you give the final verdicts. All right. Let's see your hands. I'm expecting to see like everybody raising up their hands. Okay, we have Leo. Okay, Raymond, go on.
Okay, good evening, sir.
Good evening.
I'm thinking it's pneumonia, because there is.
Continue.
I'm thinking it's pneumonia because there is like consolidation on the right side, like opposite the cardiac fillet. There is a consolidation, if I'm not mistaken. So I think it's pneumonia. But I'm trying to like picture the air bronchogram, and I'm not like actually I don't know if what I'm seeing is it. So I will not like speak on that. So thank
All
you.
right.
That's
So
what I have to say.
okay,
All right,
thank you very much.
let's see if we have other person. Any other person wants to try? Any other person wants to try? Away. Okay, Radquinin, please go on. Thank you very much, Raymond.
Okay, so I think probably by tomorrow people will be more confident, because we'll still do pathological patterns tomorrow. So if you are looking at the image, and then we said the first thing you are supposed to do if you are evaluating this is to look at the airways, right? I'll not spend so much time on it so that we can go to other ones. So you are supposed to look at the airways. Now you see the trachea coming all the way down to the carina. Carina is the point where the trachea divides into the right and left main bronchus. So if you look at if you look at this now, you can see that you are seeing this radiolucency, which is air, of course, inside the trachea or inside the airway. You can see it going all the way down. We can see from this place, we are going all the way down, 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 down. At least, Raymond, if you are seeing this now, since you didn't see it clearly, look at this now. So if you look at this, it's going all the way down, 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 down to this area that you have, these consolidations. You can see these consolidations in this area. Even though the lungs is looking so dark, but at least you can see that there are consolidations within this area. And you can see these dark areas, coming all the way down to this affected area. This is the bronchogram that we're talking about. And this is because there is an obstruction. So the air moving through here that is supposed to, to get to this point and being exchanged is not happening. So the air remains there, and, cause that more clarity for us to see it more clearly. So this is the bronchogram. It's very, very obvious for us, to see that there is a pneumonia here. So this is a case of a pneumonia. Of course, there is fever. And I said when there's inflammation, there's fever or infection. It's productive cause, of course, because of the fluid, and there's also chest pain. So we have another case here. Clinical history, 60-year-old smoker with progressive weight loss. Remember that we know there was one particular pattern that we mentioned, weight loss. The weight loss can also be associated with any other pathology, but at least in the concept of this class, I mentioned weight loss somewhere. So the radiographic patterns are from this, this image. You have diffuse reticulonodular interstitial opacities throughout both lungs, predominantly affecting both upper lung zones. A few cavitating lungs lesion in the upper lung zone and asymmetrical enlargement of the hilum nothing. Now, the important factors here, if you come here, we have seen reticulonodular interstitial opacities, one. We have held that one. We now come and we see, cavitations. And then we are also seeing upper lung zone. Of course, the answer I've even brought out itself from everything I've said here. So which of the pathology is most likely, associated with, if you diagnose somebody of a pathology, there are other tests to confirm. So it's not as if probably when you diagnose here and they are going to say, okay, this is it. They will do other tests to also correlate and confirm your diagnosis as well, laboratory investigations.
Okay,
so I also like somebody to try.
We have Millicent Ukamaka. Millicent, please unmute yourself.
Good evening, everyone.
Good evening.
I think case of tuberculosis.
Okay, yes, case of tuberculosis. So
Raymond, do you want to say something too? Raymond is also raising his hand.
Yeah, I wanted to say the same thing as you said. In the case of tuberculosis, because as you said, the upper lung zone opacities and the hilar lymphadenopathy. So I wanted to say the same thing, that it's tuberculosis, likely to be tuberculosis.
Okay.
Right.
Yeah. All right, so you can see cavitating lesions as well, of course. Cavitations, we said cavitations are mostly associated with tuberculosis, upper lung zones tuberculosis. So yes, tuberculosis. So this is a case of tuberculosis. However, there are other tests that they do for TB. They can do TB serology, they can do gene experts, they can do, I think, Mantox. So the radiologist is pointing them. This is in fact, the chest X-ray is more like saying this TB, because sometimes they can do this blood serology test and they can be able to know if this person has a TB or not. But most of the time when they send them for X-ray, they want to know how bad it has destroyed the lungs. That's why most of the time they send them for chest X-ray. They can easily do a blood test and know that, oh, this person has a tuberculosis. So how the effect on the lungs is mostly why they send them to do chest X-ray and to see if there's any other possible cause that could cause that. So this is an assessment here. I don't know if they are supposed to do this here. Yes, I don't know if they are supposed to do this here.
No, okay, they're not doing this here. They're just going to this
Okay.
like something they can do before tomorrow or anytime they are free. All right,
Okay.
so we'll now take questions. Are they questions? Because we have ended part 1 of this class. So if you have questions, please, this is your chance. We are now taking questions, please. Rad Cranium is ready to answer any question. Raymond has a question. Please go on. Raymond, please, you can go on with your question. Okay, Raymond is not saying anything. Rejoice. Please, you can unmute yourself and go on with your question. Rejoice.
Okay. My question is from, I think, the nodules. You talked about, was it the nodules? But you talked about something that one affects the lower zone, while the other one affects the upper zone. Is it the reticulonodular, something like that? I've forgotten it.
Okay, so we're talking about tuberculosis. That tuberculosis mostly affects the upper zone. Why? Because the upper zones of the lungs or the upper loops of the lungs are more oxygen concentrated. So these bacteria go there because it's more like a comfort zone for them. So most TB cases, you have consolidations or infiltrations within the area of the upper loop of the lungs or upper zones. But we also said that pneumonia are mostly, seen or associated with the lower loop. Why? Because they are mostly gravity dependent, and we said that particular type of pneumonia is usually pneumonia that are mostly associated with aspirations. So let's say if you swallow a saliva is not supposed to be within the lungs, and probably the saliva gets to the lungs and irritates the lungs. The area of the lungs that will likely be irritated is the lower zones, because of course, as the saliva is passing through the bronchus, it goes to the dependent portions of the lung zones, which are the lower zones. So I think that's why I mentioned that.
Thank you.
Okay. Is there any other question?
All right. Okay, I think.
Yes, I have a question.
Okay, Raymond, please go on.
Please, I'm having a little bit of confusion with the pleural pattern, because you said
Okay.
that normally it's a potential space, but you're not supposed to see the pleural cavity. Then you made mention of, for example, in some cases, if there is let me say there is a puncture to the lungs and the air like escape the lungs and fill the pleural cavity, that we're going to see the dark um, let's say dark covering or shadow of the air that is inside the pleural cavity, and then we're also going to see the, I think you say, the line showing the collapsed lung. So you see the little amount of air that is inside the lungs, and you also see the air that is inside of the pleural
Thorax.
cavity. Yes, thorax.
Yeah.
But now the picture that you sent, the one that Sabeni answered for pleural pattern, I was thinking and I was hoping I would see the thing you said, that the lungs will be deflated, and then we'll see the demarcation between the air in the pleural space and in the remaining air in the lungs. So I don't know that particular image you sent. I don't know if you can explain that particular image for me. Like what is the thing that, like what is the cause of that particular pleural pattern, that particular image you sent? Because when you explain pleural pattern, I just pictured the other thing you were saying. I pictured it in my head. Then when I saw the image you sent on the pleural pattern question, I could not correlate it again. I was confused. So I don't know if you can explain like that particular image on pleural pattern and like tell me how this is a pleural pattern. Thank you. I don't know if you understand my question.
Yeah. I get you. So you say when we say pleural pattern, when we started talking about the pleural pattern, we said ideally we are not supposed to be seeing the pleural space, because of course it's a potential space. There's no actual space in the body. I'm re-emphasizing this because most people think there's a space. There's no actual space. You can only have a potential space. A space that if there is fluid, if there is a mass effect, something can get to fill up the space. But you can't see an empty space and there's nothing there in the body, most part of the body, if not the entire part of the body. And this is the same thing with the lungs. So you are not supposed to see this pleural space, but there are some things that can fill this space and, make you to see them. Okay, I think the image is being shared here. Thank you very much. So, and can make you to see them. And we consider these things as being, pathologies or pathological patterns in, pleural diseases. So you can have fluid, and by fluid, I mean it could be blood, which is hemothorax. It could be just normal fluid, serous fluid, which is hydrothorax. It could be pus, which is empyema. It could also be, anything. It could also be mucinous collection can also be there. So generally, they consider this fluid as a fusion. It's only history most times that helps to differentiate it. Heart failure can cause pleural effusion. Accidents can cause pleural effusion. This time around it to be hemothorax. And they can only adequately call this hemothorax because of the history. Maybe they will see fractured ribs and the rest. But you will see blood accumulation, not like blood, it will still be looking white. That's why I said most of these things are just looking white and dark. So history helps them. So for a radiologist to convincingly say this is hemothorax, there must be a convincing history of maybe a trauma and a seeing fractured ribs and the rest. So fluid can accumulate in this space, and we call this pleural effusion. It's still a pleural pattern. But the one you are making reference to is the one I said when you have air. Now, air is not, if you look at this image that Wari just shared now, I don't know if Wari is sharing it, yes. If you look at this image, you can see area of, radio opacity, which is fluid, extending from, you can't even see the right costophrenic angle. You can't even see it. It's obliterated because fluid has filled the entire space and has gone way up to the, in fact, even covering the right border of the heart. So because it is white and because, it is not within the lungs parenchyma, it is definitely a pleural disease. And because it is a pleural disease, of course, this is pleural effusion. But if we are talking about pneumothorax is air, and we said that air is radiolucent or air is dark. So that means if you have air within the pleural cavity, it will not be white, it will be dark. And because imagine that the air in the thoracic cavity, the pleural space is black, and then the air within the remaining lungs, at least the small lungs portion that is remaining, is also dark. How can we now differentiate this? How can we see that, oh, true, this air is within the thoracic cavity? That means we now said we are going to look at carefully, at the ipsilateral thorax, that's the affected thorax, to look for a pleural line. A pleural line is the outer edge of the remaining lungs tissue, the functional lungs tissue. So if you see that pleural line, you are now also going to look for, lungs markings. Because if these lung markings are from vessels like pulmonary arteries and the rest, and pulmonary veins. So if this, air is within the thoracic cavity or the pleural cavity, it will not have blood vessel. Because of course, air in the pleural cavity is not actually an organ. So you are not going to see those lung markings, those arteries and the rest. So because these arteries are not there, those markings are not there, it can convince us enough with the pleural line, we can convincingly say that there is pneumothorax. It's different from this. It's not here. We are going to talk about it tomorrow. So this one was like an example. It's not included in this image. But definitely, we're going to talk about pneumothorax tomorrow. I think it's part of the images we are going to share tomorrow. I don't know if I've answered your question.
Yeah, you've answered. Thank you very much. I understand it now. I understand it clearly now.
All right.
Okay.
Thank you. We have Anye Kanabasi.
Hi, good evening. Okay, I have two questions though.
Yeah.
My first question is, I can hear you.
I can hear you.
My
I can
first
hear you.
question is when we were talking about the pleural patterns under the pleural effusion and all, you said we have empyema, hydrothorax, hemothorax. So I wanted to ask for my first question, is there any way that we can actually distinguish on a radiograph, like which is which, if it's hydrothorax, if it's hemothorax, or empyema?
Okay. Is that all?
That's the first question. Then for the
Okay.
second,
Can I?
I don't know
Okay,
if to
you
call
can
it a
ask.
question. Can you like just recap the whole tuberculosis again? Like it was kind of confusing.
Okay, is it the pattern on the chest radiograph or tuberculosis itself?
It was actually hanging, so I was not really following. That's why I said, please just recap.
Okay, I will just try to be brief in case we have other questions. So I will
Okay, thank
start
you.
with the first question. You said, how can, since we are saying this is just an effusion, how can we differentiate hemothorax from hydrothorax from empyema? Well, there are some features that can give you a clue to what the pathology may be. And one of the most significant feature is the history. So let's say somebody has a road traffic accident now, and they rush the person to your facility, and you do a chest x-ray and you see enormous pleural effusion. It's most likely pointing towards hemothorax, there's blood in the thorax. Or let's say somebody visits your facility and then the person is having difficulty in breathing, no accidents, and the person comes to do a chest x-ray, and from the chest x-ray you are seeing that the heart is so big and you see pleural effusion. Of course, that effusion is definitely caused from heart failure. Heart failure can cause effusion. How can it cause effusion? When the heart is pumping blood, the force at which the blood is moving within this blood vessel is called the hydrostatic pressure. So there is also an opposing pressure from tissues, and this pressure is called oncotic pressure or osmotic pressure. So meaning that you need these two pressure to balance fluid at wherever they are. And the most important factor in tissues that maintains this fluid balance is albumin from the liver. So albumin encourages, it keeps that oncotic pressure active because it's a protein. And then the heart, with the force is pumping the blood, keeps the hydrostatic pressure active. If any of them fails, like for example, you have liver failure, you have fluid accumulating everywhere in the body. If you have the heart failing, the heart will not be able to keep the hydrostatic pressure. Fluid will accumulate in the pleural cavity, pericardial cavity, all the cavities in the body. If you have the liver failing, that means albumin will no longer be working. That means you also have this ascites. That is what might cause hydrothorax. It's still pleural effusion. Now, the only one that even has a clue to maybe how it might be looking on a chest x-ray, which is related to pus formation, is empyema. And empyema has this biconvex pattern. There's no the way something looks like a convex. So empyema will have more of a biconvex pattern because it's a pus. Just like saying a pyogenic thing. It might form nearly like a mass, but it's still fluid that comes together and then it's pus-like. So it has this biconvex pattern looking somewhat round, as if it wants to be round. That's what the biconvex means. So it have this side bulging out and it has this side bulging out. And that's the clue that can give them to empyema. So, but the issue, the limitation with chest x-ray, if you go to machines like if you do CT where you are working now, the radiologist will simply do Hounsfield units. So there is Hounsfield unit for blood, there is Hounsfield unit for fluid, there is Hounsfield unit for pus, for organs and the rest. So sometimes when a radiologist on a CT sees fluid collection, they can simply click on the Hounsfield unit. The Hounsfield unit will be able to tell them if that fluid is of blood origin because of the density. And I hope you know what Hounsfield unit is. So the Hounsfield unit will be able to tell them, oh, this thing is blood, or because of the unit is giving me from Hounsfield. But we don't have such modality in X-ray. So what they rely strongly in X-ray is history. So if somebody has an accident, rushes to your facility, is likely a hemothorax. So I think that is your first question. Your second question is, you asked me to recap on tuberculosis. So we said that tuberculosis is a granulomatous disease and is actually caused by mycobacterium, right? So because this TB, is a bacteria that relies more on oxygen, it needs oxygen for survival. It finds its way to the upper zones or to the upper lobe of the lungs and remains there, feeding on that high oxygen area. And over time, they tend to destroy the lungs. They constantly secrete fluid, that causes obstruction, and that area of the lungs is not receiving air, and it destroys the areas of the lung begin to destroy. Now, it means in the means of your body trying to save yourself, it sends some macrophages to go there, to go and try to fight this bacteria. Just like the similar thing happens in atherosclerosis. If you have been reading, you have heard of atherosclerosis. Your body is trying to fight this low density lipid. At the end of the day, it causes more problem for you. So your body is going to this area where you have, yes, I think the image is here. It's going to this area where, you have this bacteria being concentrated. And when trying to fight them, the macrophages in turn will cause cavitations within that area of the lungs tissue. That's why we always say that, cavitations are mostly associated with tuberculosis. And when we started, we say the patient might have weight loss, might have dyspnea, will have productive cough, might have difficulty in breathing, and so on and so forth. And this is pulmonary tuberculosis. We also say we have miliary tuberculosis, though our concern here is not miliary tuberculosis, because miliary tuberculosis more like runs in the blood. It can go to anywhere in the body. You can have it in your test, you can have it in the liver, have it in the spleen, have it in the ovaries, have it in the testicles, and the rest. So pulmonary tuberculosis are mostly, located in the upper zones or the upper lobes of the lungs, because these areas are oxygen concentrated. I don't know if I've answered your two questions.
All right, thank you. Has your question be answered?
Yes.
All right, we have one more person as we'll take as the last question for today. We have Millicent Ukamaka. Please, Millicent, unmute yourself and ask your question.
Okay, sorry, please, can you throw more light on that intestinal pattern? I did not get it at that point you were explaining it. So I don't know if you can throw more light on it.
Okay, so we say that, we have alveolar as a unit of the lungs, and the alveolar is where gaseous exchange takes place, right? But the lungs as itself, just like we have bone in the body, need structures to support this alveolar. And these structures are considered as the interstitium, right? So because these are also cells or these are also tissues, they can also be diseased. So, but the disease pattern will be different from the alveolar pattern because you don't have gaseous exchange within the interstitium, right? So most of the diseases that affect this interstitium, which are the supporting tissues of the lungs, are mostly fibrotic diseases. You can have the tuberculosis, pulmonary fibrosis, even sarcoidosis. And this interstitium, they have, lymphatic drainage. That's why sarcoidosis is very possible in them. They contain lymphatic drainage. So this interstitium, over time, maybe due to, tuberculosis, due to any disease that is affecting them, can become hard, and they can become even nearly destroyed and can show on chest X-ray as nodular patterns, can show as reticular patterns, can even show as both of them, reticulonodular patterns. You can even see both of them on one chest X-ray. And this will tell you that, oh, this is an interstitial pattern, or this is an interstitial disease. And because, remember, the interstitium are not part of gaseous exchange, they are not going to show the air bronchogram, meaning that the lungs is going to be fully aerated. Air will still fill the lungs as it should, except when it gets so severe that the lungs get so fibrous, you can even have, an entire segment being fibrous that is become non-functional. That's when you can now say, okay, oh, air might not be getting to that side. But at the initial stage where these are diseased, because it's not, the primary site is not where gaseous exchange are taking place, the person will still be breathing normal and not even knowing what is happening. Might not even be coughing, because we said before that for somebody to cough, there must be an obstruction. And the obstruction that we are talking about is obstruction to airflow. So if the air can still get to the alveolar and the person is still, having normal gaseous exchange, this reticular disease or this interstitial disease can, occur for a period of time before this person can even find out, oh, this is what has been happening to me and all that. I don't know if you understand.
Yes, I get it. Thank you.
Yes, but they also depend on the disease. If it is tuberculosis, because tuberculosis affects the interstitium and also affects the alveolar as well. So definitely the person will cough with tuberculosis.
All right, that is it for our questions for today. Thank you very much, Rad Cranium or Rad Anyekeme Samuel. Thank you very much for today. So we'll have that for today. This is part one. Take note, this is part one. So tomorrow we are going to continue on this. We are going to look at other pathologies and how we can relate the pathologies to the patterns we've learned today. So you can just, or somebody has a question. Okay, please. Okay, just ask your question. Okay, your hand is down.
No. It's not like an actual question. I
Okay,
believe
okay.
I believe you are rounding up, like you're trying to round up.
Yeah, yes, we are.
So I want to bring like to your notice that you gave us an assignment yesterday for
Okay.
that first off. So I believe some of us here have done it. So I don't know if you and our chief here, Chief Premium, can questions are subjective. Like I might see something and this person might not see it, or this person might see something and I might not see it. So I don't know if like want to hear from the horse's mouth if you can answer the question. So let us know if we're actually learning something. I don't know if you understand what I'm saying.
Yeah, I get you. Don't worry.
Yeah.
We have plans for that. We have plans.
Okay.
Those that I've done. Have you been able to submit it?
No. The time I texted you, said that you make an avenue
Okay.
for that before the class.
All right. So I think we are done with this. For those that would want to submit the assignment, I think I've seen some submissions already, about 5 or 6. Rejoice, do you want to ask a question? You want to also make a comment?
No. I wanted to talk about the submission of the assignment. I thought there was a
Okay.
place that we can easily submit it there.
Okay. Have you submitted yours?
Yes.
How do we submit it?
Create it as a file, then submit it.
Okay.
Yes.
So
Okay,
just create it
thank
as a
you.
file and submit it. Utibe Abasi.
Okay, thank you.
All right, welcome, Raymond. Utibe Abasi.
Good
Your hand is
evening.
up. Okay, good evening.
The material, it's not a question though. Please, as regarding the material for yesterday and today, please, when should we be expecting them?
Yesterday is already there. The material for yesterday is already there. Just check your class work, or rather check the stream on the classroom. You're on the classroom, right?
I believe so. And also, please, the assignment questions, can it be reposted for those who didn't get it yesterday?
Even if those that just joined, for those that haven't joined the classroom today, they can still see it. So it's still there, whether you joined today or yesterday or 5 years ago. So it's still there. So just check the stream, go to the Google Classroom and check on that stream. You see the assignment and the materials there. So this as well will be posted there. So after the class, before the end of today or tomorrow, you should see this as well. All right. So thank you very much. So we are looking forward to tomorrow, where we'll have part 2 of our introduction to pathological findings. I want to say thank you. And thank you very much, our instructor for today, Rad Anyekeme Akpan. We hope to see you tomorrow. And I know that you have so much in store for us. All right, so in the absence of any question, we don't expect any question. I would say good night and have a very wonderful night rest. See you tomorrow. And please, the link is still the same. The link for all our classes, they are still the same, please. So tomorrow by 8, use the same link and join, please. All right, thank you very much. Good night. Bye.
Thank you.
Bye.
Thank you.
Thank you very much.
Thank
Thank
you
you.
very much.
Thank you, sir. Thank you, sir.
Thank you very much.
Thank you.
So
Thank
your
you.
voices can be heard. Everybody's voices can be heard when you yeah, hearing your voices now.
Okay.
Okay.
Yeah, thank you, sir.
I thank you for joining. I think I'll just end it.
Thank you.
You're welcome.